Hi guys, this is Shahul. Today I am going to give a detailed history about protein energy malnutrition. To begin with, it is a pathological condition arising from lack of proteins and calorie intake in varying proportions in infants and children. Like in varying proportion means if calorie intake is more with reduced protein intake, that leads to a different manifestation. If both calorie and protein intake is less, that leads to a different manifestation. That's why in varying proportion is being used. So we know that the cause of protein energy malnutrition is because of inadequate intake of food. Either the intake is less, or either the absorption is not proper, or some other pathology is there which does not lead the body to absorb properly, to store properly. So we broadly classify the causes of malnutrition as primary and secondary causes. Primary causes include lack of adequate intake of food, which include poverty can be one of the reason. Traditional food fads where the children are not allowed to eat many of the nutritious foods, or sometimes girls are not allowed to. There will be sex discrimination where girls are treated in an inferior position, and all these things, and poor socioeconomic classes play a very important role in the cause of protein energy malnutrition. And also to be noted as cleft lip and cleft palate. So what does this mean? Cleft lip and cleft palate means, in if the child is having cleft lip or cleft palate, the sucking will not be proper, and that leads to protein energy malnutrition. And very important is the nutrition of a mother plays a significant role in the nutrition of the children. So if the mother is malnourished during her period of pregnancy, automatically that malnourishment will definitely have an impact on the growing fetus also. So in case of intrauterine growth retardation, there will be protein energy malnutrition when the child grows on. And the secondary causes include, what does the word secondary causes mean is, the intake of food is proper, but still the child is having malnutrition. That might be because of two reasons. One is malabsorption. Though the intake is proper, it is not absorbed in a proper manner. So malabsorption is one of the reasons for PEM, and also chronic infections and illness, which does not allow the body to store food. Or when there is increased metabolism of body, automatically there is increased consumption of energy, which leads to protein energy malnutrition. Okay, done. Now coming to its classification, we actually, it is not classification per se. It is the assessment of protein energy malnutrition. How do we assess it? We assess by three categories. One is weight for age. Next one is height for age, and then is weight for height. So what does the word weight for age mean? Weight for age means that weight of a child in comparison with the weight of a normal child of age being same. So weight of the malnourished child, ratio of weight of the malnourished child to the weight of a normal child whose age is same as that of the malnourished child. So when we compare that, when the child is having reduced weight for height or decreased weight for age, we call it as underweight. And that underweight can be because of either acute malnutrition or chronic malnutrition. And then next we have a height for age. I mean, that is the ratio of height of the child to the height of a normal child who has the same age, of the same age group. When the height of the age of the child is less, we call it as stunting. And stunting is because of a chronic malnutrition, because height is a process which occurs slowly. And very important note is, height cannot be decreased back. That's why only in case of a chronic malnutrition, the height decreases and stunting occurs. So stunting indicates chronic malnutrition. The third one is very important, is weight for height. It is a weight of the child, weight of the affected child to the weight of a normal child who has the same height, having a age group of the same height. Now here, when there is decreased weight for height, we call it as wasting, and that wasting indicates acute malnutrition. Whenever there is acute malnutrition, there is severe wasting of the muscles of the body, and there will be decreased weight for height. And we have several classification to grade protein energy malnutrition, like IAP classification, WHO classification, Wellcome Trust classification, Gel Life classification, and Gomez classification. Very important is IAP classification, where we classify based on weight for age. First of all, we consider the 50th percent as the so not 50%, we consider 50th percentile as 100%. That is a perfect normal child. So 50th percentile is a perfect normal child. So in comparison with the 50th percentile, considering it as 100%, so when in comparison with that, when it is more than 80%, when the weight for age is more than 80%, we consider that as normal. 70 to 80 is considered as grade 1 malnutrition, 60 to 70 is considered as grade 2, and 50 to 60 is considered as grade 3, and less than 50% of the 50th percentile is considered as grade 4 or severe malnutrition. So it is also important to consider who classification, Wellcome Trust, Gel Life, and Gomez classification. You can note it on your, you can read it on your textbooks. And then coming to the presentation, how does a protein energy malnourished child present with? We broadly classify the presentation of a PEM into two things. One is Marasmus and one is Kwashiorkor. Okay, done. So what is Marasmus? What is Kwashiorkor? These are two manifestations of a same cause. These are two manifestations of a protein energy malnutrition. So we have to know that one important point what we have to notice, the cause is same, but how does a child go for marasmus or how does a child goes for Kwashiorkor? To know this, we have Mr. Gopalan has produced a theory that is called as Gopalan's theory of adaptation. So let us consider this. This is what Gopalan's theory of adaptation is. So considering is the manifestation of either marasmus or Kwashiorkor is based on the ability of the body to adapt to the reduced intake of food. So if the body adapts to the reduced supply of calories and protein, automatically it leads to a different manifestation. If the body does not adapt to the decreased supply of calorie and protein, that leads to a different manifestation. Let's see how. Now, considering this, there is a reduced supply of calories and proteins here. So if the body adapts it, we know that how does the body adapt is, whenever there is increased intake of food, there is increased secretion of insulin. We know that. So whenever there is decreased intake of food, automatically the body adapts by decreased secretion of insulin. If there is decreased secretion of insulin, automatically there is increased secretion of cortisol. So considering the function of insulin, we know that insulin is a what hormone? It is an anabolic hormone. So whenever there is decreased secretion of insulin, automatically there is increased catabolism because of the unopposed action of cortisol. So automatically, because of increased catabolism, the protein gets breakdown, the proteins of the muscle get lysed, the fat gets lysed, that leads to increased catabolism. So what happens is that increased catabolism leads to, on one side it leads to muscle wasting, on the other side protein breakdown to form an amino acid, so that amino acid gets into the blood. So automatically the blood glucose level, the blood amino acid level remains normal. Though the intake is less, the blood amino acid level remains normal because amino acid is not coming from the food, but instead it is coming from the normal muscles being broken. Okay, so what happens, since amino acid level in the blood is normal, albumin level will also be normal. That's why that manifestation will not have edema at all. But because of muscle wasting, there will be severe muscle wasting in the body. So whenever there is massive muscle wasting with no edema, we call it as what? Marasmus. So that is what marasmus is. When the body adapts to the decreased intake of calories and protein, automatically that child goes for marasmus. Now let's see what happens if the child is not going for adaptation. So if the body does not adapt to the reduced supply, automatically there will be normal insulin level. So whenever there is a normal insulin level, what happens is insulin is secreted at a larger rate. Automatically what happens is, since insulin is an anabolic hormone, there is decreased catabolism in our body. So the protein in our body are not converted into amino acids. So automatically the amino acid level in our body decreases. So when the amino acid level in the body decreases, automatically the albumin level decreases. So when the albumin level decreases, automatically there is edema. There is hypoproteinemia, automatically there will be edema. And also we know that there is decreased catabolism, which since there is no catabolism at all, there is no muscle wasting. So whenever there is no muscle wasting with a reduced albumin level leading to edema, that manifestation we call it as Kwashiorkor. So when the body adapts to the reduced intake of calorie and protein, it leads to marasmus. And when the body does not adapt to the reduced protein and calorie intake, that leads to Kwashiorkor. This is what being explained by Copelan, and that we call it as Copelan's theory of adaptation. Now coming to the presentation of marasmus. So marasmus has both external presentation as well as internal pathology. So externally, the child will have loss of subcutaneous fat. So all the lipids and muscles get broken down. So since there is no subcutaneous fat at all, the child will be having an appearance of an old man. So there will be old man appearance. There won't be proper growth at all. So there will be microcephaly. Since there is no subcutaneous fat in the abdomen, the child can go for a scaphoid abdomen. But at some times, because of reduced protein and minerals, there will be hypokalemia. Whenever there is hypokalemia, there will be hypotonicity of the abdominal muscles leading to abdominal distension. So scaphoid abdomen is as well as abdominal distension. These both are the manifestation of a marasmus. And also we know that the extremities will be very thin. Coming to the internal pathology, there will be cardiomegaly because of reduced thiamine. So whenever there is reduced minerals, automatically the heart will have increased workload, and also the heart will go for cardiomegaly. And also considering the gastrointestinal tract, definitely the gastrointestinal tract will go for mucosal atrophy. So if it goes for mucosal atrophy, once again absorption is impaired, that leads to malabsorption. Malabsorption leads to mucosal atrophy. Mucosal atrophy leads to malabsorption. So there is a vicious cycle over there. And also we know that there is insulin level, since the body adapts to it, insulin level is decreased and there is atrophy of intercostal muscles. So this is how the child with marasmus present with. And now coming to the grades of marasmus, we grade according to we grade according to the severity, and the severity is based on the loss of fat. We know that, I mean, the fat, so loss of fat. So grade 1 is loss of axillary fat. From this, what we come to know is the first fat that is being lost whenever there is a malnutrition is axillary pad of fat, and then buttock fat gets lost and chest fat gets lost, and at loss buccal pad of fat is also lost. So this means that buccal pad of fat is a fat which gets destroyed at the later stage. So whenever the child is having loss of buccal pad of fat, that indicates a severe marasmus. And complications of marasmus include hypoglycemia, hypothermia, infection. This hypoglycemia, hypothermia, and infection occurs in a, I mean, they actually, if one occurs, automatic. If two occurs, automatically third one occurs. We call it as a triad of malnutrition. Infections, electrolyte imbalance can be there. So since when marasmus is at a chronic stage, mental retardation can also be there. And how do we treat a marasmic child? The aim of the treatment is to give a proper nutritious food to the child, so that automatically the child regains its growth. But initially, the bodies will not have that ability to absorb the maximum amount of food. So we start the food with small quantities. Normally, the requirement of calories for a normal child is 150 to 200 kilocalories per kilogram per day. But we don't give it in the first day. We start with 100 or 50 to 100 kilocalories per kilogram per day. Then we gradually increase to 150 to 200 kilocalories per kilogram per day. And the protein requirement is 2 to 3 gram per kilogram per day. And we have to give isodense food. Isodense food is one where the quantity of the food is less, but the quality of the food is high. I mean, a food with lesser volume with a greater caloric food. I mean, for example, if we give rice, but if we add some vegetable oil to that, automatically the calorie content increases without increasing the volume of food. So isodense food has to be given along with mineral supplementation like iron and potassium if there is deficiency. Now coming to the next manifestation, that is Kwashiorkor. Kwashiorkor, the word Kwashiorkor means influence on the older child when the next baby is born. This is what the Greek meaning of Kwashiorkor is. And the three essential clinical features or the triad of Kwashiorkor is: one is retarded growth, next is pedal edema will be the edema, and then very important is psychomotor change. This is how Kwashiorkor differs from a marasmus. In a marasmus, the child will be absolutely normal. The sensorium of the child will be absolutely normal. But in case of Kwashiorkor, there will definitely be an altered sensorium. So this is how a Kwashiorkor child will present. So let's see what are its external and internal pathologies. There will be decrease in body weight, nearly 60 to 80% of body weight, and generalized fast and pitting edema will be there. Initially, there will be edema at the legs, that is pedal edema followed. Edema will occur at the dependent site. And as I told you before, that it definitely Kwashiorkor will present with an altered sensorium, and that altered sensorium can be irritability, lethargy, or apathy. And very important is hair changes and skin changes. Very important point to note is this: hair and skin changes will not be that common in marasmus as it is common in Kwashiorkor. It is very common in Kwashiorkor. The hair will be thin, dry, brittle, lusterless, easily pluckable. And the specific sign, we call it as a flag sign. Flag sign means the child will have alternate white and black bands in the hair, and that is because of episodic malnourishment. Whenever there is good nutrition to the child, the hair will grow black, and whenever there is reduced nutrition to the child, automatically the melanin will not function properly, automatically lead to malnourishment, white color of the hair. So automatically when the malnutrition or malnourishment is episodic, automatically the hair will have an alternate white and black bands. That we call it as a flag sign. And also very important is hypo and hyperpigmented patches. This is due to altered production of this melanin. That's why we have hypo and hyperpigmented patches. And because of hypokalemia, we will have pot belly because of hypotonicity. Considering the internal pathology, the child will have hepatomegaly because of fat accumulation over there, vitamin A deficiency, mucosal atrophy, impaired immunity, cardiomegaly, and hypokalemia can also be there. And coming to its grade, actually, you remember one thing, we graded marasmus based on the loss of fat. Now here we grade Kwashiorkor based on the edema we have. Number grade 1 is pedal edema. Initially the edema will be there in the leg, then it is followed by facial edema, then we have edema of paraspinal muscles, at last we have edema of the skin. At last, we will have edema of the skin. That is what ascites is. And coming to its complications, same as it is in the case of marasmus. One is hypoglycemia, hypothermia, infections, electrolyte imbalance, and dehydration. So treatment is same as that of marasmus, but Kwashiorkor is a bit more severe. That's why we have to monitor it very carefully. Chances of the child going for complications like hypokalemia, hypothermia, hypoglycemia, electrolyte imbalance is more in case of Kwashiorkor than in marasmus. So the child has to be monitored very carefully. This is how the treatment of marasmus differs from the treatment of Kwashiorkor. In Kwashiorkor, we don't give it immediately. We start with a less caloric food, and we increase it gradually. And the calorie recommended is 150 to 200 kilocalories per kilogram per day, with protein recommended of 3 to 4 grams per kilogram per day. So we give it gradually and automatically there will be signs of recovery. To assess the signs of recovery, we assess on the return of appetite. There will be good weight gain. If the weight gain is good, then there will be weight gain of 10 gram per kilogram per day, and there will be normal motor activity. At last, we just have a broad view. A broad view over difference between marasmus and Kwashiorkor. Marasmus is because of decreased calorie and protein intake, but Kwashiorkor is because of only decreased calorie intake. And the common presentation of marasmus is below 1 year, and Kwashiorkor is 1 to 4 years. Marasmus is very common, and Kwashiorkor is very rare. Yeah. Nowadays, we don't see cases of Kwashiorkor at all. And I told you before, in marasmus, the child will have a perfect sensorium, that the child will play, it will be alert, active. And in Kwashiorkor, there will be altered sensorium. The child can have either irritability or apathy and lethargy. Weight loss will be less than 60%. Weight will be less than 60% in case of marasmus, and 60 to 80% in case of Kwashiorkor. Edema will be absent in marasmus, will be present in Kwashiorkor. Muscle wasting will be marked in marasmus. Though there is muscle wasting in Kwashiorkor, it will be obliterated because of the presence of edema. That's why we don't see much of muscle wasting in Kwashiorkor. Skin and hair changes will be present in marasmus only in severe cases. Normally it will be absent in marasmus, but definitely skin and hair changes will be present in Kwashiorkor, and there will not be any organomegaly in marasmus, and hepatomegaly because of fat infiltration will be there in Kwashiorkor. Thanks for watching this video. Bye.